Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez here, hosting another important health topic. We know this is Heart Month. We just celebrated Valentine's Day. Happy Valentine's Day to all our viewers and our listeners. And obviously in Heart Month, we're focusing on heart health. And we've brought a cardiologist, a heart doctor, to talk to us about heart health. And you know, sometimes when the heart is not so healthy, you need a doctor to help you out, kind of make your heart healthy. So I brought a friend and a colleague, Dr. Dean Heller. Welcome.
Thanks for having me. Appreciate it.
All right. So Dr. Heller is a cardiologist. Tell us a little bit about you and your practice and what do you do?
Sure. So I'm a general cardiologist and an interventional cardiologist. So I've been in practice in Miami for over 20 years after coming from the Northeast. So I do just general cardiology, prevention, treatment of medical conditions, but also I'm an interventional cardiologist. So when people have a problem where they need some fixing of their arteries of their heart, I bring them to the cardiac cath lab and do some work on their coronaries.
All right. So what are some of the common conditions and heart conditions that we're going to see our viewers and our community deal with that are going to come and see you?
Sure. So the heart, of course, is a muscle, and the main function of the heart is to pump the blood to the body. But there's a number of things that can go wrong with the heart. We need an electrical system to help provide the impetus for the heart to pump, an electrical system. The heart is, of course, the muscle, so the muscle can fail. The valves, which make the blood to go forward and not backwards, can also fail. And then importantly, the most common disease in the U.S., of course, is coronary artery disease, which is blockage of the heart arteries that supply the heart with blood, giving the heart oxygen to do its function. So all of those things can have issues. Of course, the number one killer in America is coronary artery disease. So when we're talking about heart disease, coronary disease, of course, the most prevalent and the one we spend a lot of time on.
All right, so let's focus a little bit on coronary disease, and let's talk about that coronary disease. Somebody may have coronary disease. They come and see you. Maybe they have complaints of chest pain. You do some testing initially to kind of find out if they have coronary disease. What is that like?
Sure. So we do workups on people with just general coronary disease. People may have symptoms, may have chest pain, they may just have risk factors for coronary disease, in which case you do testing such as stress testing, EKGs, nuclear stress imaging, echocardiograms, and that helps us guide who needs more aggressive treatment, who needs cardiac catheterization. We also treat people who have heart attacks. Heart attack is, there's over 500,000 a year in the U.S., so it's a number one killer. Wow. And so we also treat people with heart attacks. So those people you're obviously not seeing in the office. You're seeing them come right to the hospital with their heart attack, and we bring them right to the cath lab. And we want to open up those arteries within 60 minutes. So that's, obviously an important part of our job and something we enjoy. And although you take care of sick people, you can help them very quickly, and they're all super appreciative.
Yeah, well, you guys call that door to balloon time, right?
Door to balloon time, correct.
Yeah, so for our viewers, there's a term that came, and I saw this develop. You've seen it develop in your career, where by the time the patient hits the door of the emergency room to the time that the balloon is opened up and the artery is reopened has to be under 60 minutes. Is that right?
Yeah, I mean, that is our goal. It's changed a little bit, so it's really under 90 minutes, but 60 minutes is definitely our goal.
All right.
And of course, we didn't have this back when we were in medical school.
Training, yeah, we didn't know the importance of that.
When I was in medical school, there was even no angioplasty, but certainly there was no primary intervention for heart attacks. So it's been an exciting transition, and we've helped a lot of people over the years, and we can see that through the mortality rate from heart attacks go significantly down since we started doing that.
Wow. But still 500,000 people having heart attacks in the U.S. a year, and still the number one killer.
Yes.
Oh my God, incredible. Yeah. All right, so for our viewers, we have a lot of toys today. Dr. Heller brought a lot of toys to show us, some of the things that he uses and his colleagues use to help diagnose and treat a lot of this heart condition. So if somebody who has coronary artery disease, you have to do a cardiac cath on them.
Correct.
So they obviously go to the cath lab and they have an intervention and they have catheters placed. And eventually they put in stents. And we talked about this before. These stents are so small, they're even hard to show. Yeah. So talk to us about it. Maybe show us some of the things that occur with a cath lab.
Sure. So I brought a bunch of stuff here that we can look at. So, of course, the coronaries that supply the heart is, like we said, a muscle, and the heart arteries sit right on top of the heart. and they're small. The average artery of the heart is about 3 millimeters, so small. So what we do is we put catheters in either through the wrist or through the groin, pass the catheters right up through the aorta, and enter the ostium, or the beginning of the heart arteries, and inject X-ray dye right into the heart arteries. So what we'll use is a catheter just like this. I don't think that's going to show too well there, but you can see how small these are. We use different shaped catheters, and we help guide these right into the heart artery. And we inject X-ray dye through a manifold, which just injects dye into there. And then the dye comes out the end of the catheter right into the heart artery, and it shows us where the blockage is in the heart arteries. We have a number of different shaped catheters for the different coronaries. And then we also have a catheter that we can look at the heart muscle. It's a similar little variation, but we call it a pigtail, and you put that right into the heart muscle, and we can see how the heart pumps during the catheterization. So that's the basics of looking at the coronaries. During a catheterization, we also gather some other data. We look at oxygenation, we look at the pressures inside the heart, we evaluate for these valve abnormalities that can happen. So when there's leakiness of a valve, we will see it. When there's closure or stenosis of a valve, we can measure the pressures and look at that. So we look at all of the different things that can happen to heart diagnostically, so we know exactly how to treat those people.
And then through these same catheters, or through this procedure, you guys are also putting the stents in there as well, right?
Correct, yeah.
And this is done all through these catheters as well.
Correct. So through the similar catheters, so similar size catheters, we will, if we see a blockage during catheterization, we will of course, have a little discussion with the patient on the table and tell them the risks and the benefits of the procedure. And we will go right ahead and right at that time, put a balloon in, open it up with a balloon, and then place a stent. So for us, it's obviously something we do every day, so it's pretty simple, but obviously it looks a little complex. We put little tiny guide wires. These are not going to show up on the camera, I can see. But they're just very small catheter wires. These wires thread right into the heart arteries, and then over this wire, we will place a balloon, open up the balloon right in the blockage, and then over the same wire, put a little stent, open that up, and that helps maintain the artery to stay open and decrease the obstruction of that artery, restoring the flow and restoring the blood supply to the heart.
And these type of treatments have really decreased the amount of open heart surgery that people have needed, right? So
yeah, absolutely.
How has that impacted the care? And patients now have catheterizations. They go home. I don't know whether they go home the same day, next day. They have stenting, and they avoid the morbidity of open heart surgery as well, right?
Yeah. So just like your field, I remember back in the day when you were doing the gastric bypasses that were fraught with issues.
Open patients,
so we have come such a long way over the years in just the different things that we're doing. The number of angioplasties, of course, when angioplasty started in the late 80s to now, it has far surpassed the number of bypass surgeries, which has decreased over the years. And we are more and more aggressive over the years because our tools have gotten better and better. We can open up blockages that we couldn't before. So for example, calcium in the heart arteries, which is just calcification, hardening in the arteries, as people know, makes it very difficult to use certain catheters inside the arteries. So we have some great tools now which help us with calcium. So one thing that just came out just within the past few years is intravascular lithotripsy. So the same lithotripsy that they use for kidney stones, we now use obviously a different degree of it. We use inside the heart arteries to cause these pulsations, and it breaks up the calcium, and it makes it easier for us to deliver these stents and open up the blockages. Where back, even before there were stents, of course, or before these new devices, you wouldn't even attempt those type of arteries. And now we're doing super complicated blockages in the heart arteries. There's been it's really been amazing to see just the progression over the years.
Yeah, the progress and the progression of medicine. That's awesome. Now, you mentioned, let's transition a little bit. You mentioned during the catheterization, you guys checked valves, right? Sure. So let's talk about some of the valvular disease. Of course, we're talking about the heart month. The heart, obviously, the valves are important to keep the blood flowing in the correct direction. That's what you said. So now, what are some of the valve problems people can have, and what are some of the ways you guys can help them?
Sure. So the arteries, this is our most common procedures, the catheterization, fixing the heart arteries. But the valves have become a more and more increasing number of procedures that we do, which these have only been around for about a decade or so, a little bit more maybe. So the valves themselves can either become scarred and decrease the blood flow from the heart muscle out to the body, or they can be leaky. And we can fix both of those things. So the most common procedure that is done from a valve standpoint is, a lot of people have probably heard of this, but it is a TAVR, which is a valve that's placed through catheters, and instead of open heart surgery, which obviously has a higher degree of morbidity and mortality, we can place these valves right in the place where the valve, your own valve, was, and replace them through catheters. So first we do, of course, the diagnostic procedure, measure the amount of the gradient or the decreased amount of flow that goes through the valve. And then at another procedure, you do this. And this is, of course, a more complicated procedure. These are much bigger than you can see the size of these coronary vessels. They're small. The catheters are small. These are much bigger valves that we have to place in the valve position. So the catheters are much bigger. It's a much more complicated procedure, but it's done an incredible amount of good. So this is just a model of the heart, and this is the aortic valve position. So that's the main valve that right before the blood goes into your aorta, go to the rest of the body. Your aortic valve is obviously a super important valve, and through catheters, we can place these valves right in that position, open them up with a balloon the same way we do with the stents, and replace the valve right in the same position as the old valve. And these are
one of these valves? That's one of the valves that we use?
This is one of the valves that we use. This is an actual TAVR.
And what material are these valves made of?
They're different ones. You know, the stents, they're similar to stents. There's some form of a metal or cobalt chromium. There's different, we do also have self-expanding stents for the valves. But they're all some form of, you obviously need a good scaffolding. So there's some form of metal. Wow. A lot of the stents are now cobalt chromium. They started out as stainless steel back in the day, but stainless steel was much stiffer and harder to get into the arteries. So that's why the procedure itself for the arteries was so much more difficult way back, and now it's just become incredibly easy in certain cases.
Now, let's be clear for our viewers, this is not for every patient that has an aortic valve problem, right?
Sure, yeah.
So clarify that for them, because, everybody wants, I want a catheter valve, and maybe it's not a candidate for that type of patient, right?
Well, for all these procedures, of course, we're always attempting medical therapy for everything, for coronary disease, for valve problems. So medical therapy is always our first line of treatment. But the valve, first of all, has to be obviously very severe for aortic stenosis for us to place this valve. But also there's a number of different characteristics that people have to be, you have to have not too much calcium in your aorta. We have to be able to place this valve. Now, over the years, we've actually are doing less sick and less sick patients with this TAVR. In the old days meaning 7-8 years ago, we only did the highest risk people that were too high risk for surgery. Now, over the years, the recommendations have become less and less. So we previously did high risk, then moderate risk, and now it's actually really a patient choice. So even a relatively low risk patient who may be a little older, maybe not a young person, but a 65-year-old who wants to have a TAVR rather than open heart surgery, we will, in many cases, offer to those people. So it's become much more widespread and really taken over a significant portion of the valve procedures. Now,
you mentioned, valve problems could be a narrow valve, and then you talked about a leaky valve. Are leaky valves also can be fixed through interventions that you guys do?
Sure. So I did not bring one, but we have a number of different devices to fix leaky valves. So the valve that becomes the most common to be leaky is the mitral valve. So not the aortic valve, which becomes stenosed, but the valve just before that, in between two chambers of the heart, the mitral valve, which makes people build up fluid when it leaks. We can either replace it with a new valve, just like these valves, or more commonly what we'll do is we have a nicer device called a mitral clip, where we can clip the valve where you decrease the leakiness by adhering the valve a little bit more where it's supposed to be and decrease the leakiness. So that's just an easier procedure and the most common procedure for leakiness of the mitral valve.
Now, we still have to do, not me, but somebody has to still do open heart surgery for valves, right? So not everybody could be a candidate for an aortic valve through a TAVR or through a catheterization for a mitral valve. There are still patients that have to go to the operating room eventually for valve surgery.
Sure, there are some people that are just not candidates for TAVR, whether it's their anatomy, whether it's too much calcification in the aorta. And then certainly there are some people who are just better suited for open heart surgery. A young person who's very low risk for open heart surgery, they just get a little bit better long-term result from an open procedure rather than a TAVR. So a lot of those people we would recommend open heart surgery. And of course, if they have other problems, so if you have blockage in your heart arteries in addition to stenosed aortic valve, when everything has to be fixed at one time, the surgical way to fix it is usually better.
All right. So we talked about the coronaries. We talked about the valves. You mentioned the electrical component of the heart, right?
Yes.
The electrical component is the one that kind of gets the heart going and actually helps the heart so it can, I guess, beat in a coordinated fashion. So what are the electrical problems that patients have, and how do you guys help them with that?
Sure. So the electrical system is the pacemaker of the heart. So it helps the heart to start, to stimulate it, to contract, and synchronize the heart. So, of course, my electrophysiology or the electrical doctors of the heart have a number of procedures which can fix electrical issues. So people can have slow heart rate where they need a pacemaker. You can have a fast heart rate or a tachycardia, the most common one being atrial fibrillation. Both of those things, tachycardias of many sorts, but certainly atrial fibrillation, the electrophysiology doctors can do ablations where they burn away the area that causes the tachycardia. So those are procedures that the electrophysiologists do. And then a few of the things that the interventional cardiologists do as well is one of the risks of atrial fibrillation, as many people know, is stroke. And there are people that don't tolerate the blood thinners that we commonly use for stroke prevention. When someone can't take a blood thinner and they're too high risk or they've bled already and they have issues with that, we have some devices that, oh, actually, I didn't bring those devices, but a similar device. We have devices that can close off the area of the heart, which is in the left atrial appendage of the top chamber, a little area of the top chamber. We have a device that can close that off. That's where most of the clots come from and cause stroke, and that decreases the risk of stroke by putting a device into the left atrium.
Wow.
Yeah, so there's a lot of great new devices. This is not one of those devices. It's a little device we can talk about right after this. But it's similar to this. It just has a mesh with some wiring, and it fills up the left atrial appendage and prevents the clots from going anywhere. And then those people do not need blood thinners after that.
And what's that device for?
This device, so this is a little less common, these things, but of course there can be issues besides the things that progress over the years as you get older. Some people are born with problems in their heart, which are congenital. Of course, there's some great pediatric cardiothoracic surgeons, and they are pediatric cardiologists who fix very little children with congenital abnormalities. But frequently what we see in adults is little holes in the heart. So you can have a hole in the top chambers, in the septum between the left atrium and the right atrium. And you can have a hole between the lower chambers, the ventricles of the heart. So what we can do is, the most common procedure is to close the upper chamber, the atrial closure. And this is a device which is exactly that. So this is a closure device, and we put this in through the septum. We do what's called a transeptal puncture of the septum, and you put this on either side of the atrium, and it closes it up. So we have a number of different devices for that. This is the most common. This is called the Amplacer, and it's basically like a little clamshell. So it goes a little piece goes on either side, and it closes up the hole.
Yeah, they can't see it from the perspective.
Yeah, so it is
there's
three-dimensional.
Like, yeah, three-dimensional. Yeah. So it's interesting. Wow.
Yeah. So these are far less common, but can be super helpful for people that have this problem. This hole in the top chamber of the heart can also be a cause for stroke. So some people that will have clots, like blood clots in the legs, which of course you know a lot about, When you have a little hole in the heart, those can go to the other side of the heart and cause stroke, which is obviously a major complication from those clots. So when you have that, these can close that off and lower the risk of stroke.
Wow. So it's so important to, if you have these symptoms, see your cardiologist, make sure, because there's so many conditions that you can have. And I'm hearing about all these problems that patients can have. And obviously heart disease is so common that seeing your cardiologist is very, very important.
Sure.
And is there a routine pattern that patients should be seeing their cardiologist?
Well, certainly we see a lot of people that when they start to have symptoms, so if you have symptoms that are worrisome for heart disease, chest pain, shortness of breath, sweating, recurrent symptoms when you're doing exercise, certainly any of those symptoms, you want to see your primary care doctor, and if appropriate, they should send you to a cardiologist. And then people that are just at risk for coronary artery disease, there are some people that are super high risk, so diabetics, people that smoke, hypertension, diabetes. So the people that
you've had family members with
sure, of course, that as well,
with heart disease,
that of course. So for those people, if you have multiple risk factors and certainly any symptoms, but even sometimes when you just are very high risk for coronary disease, it's good to see cardiologists to get some initial screening, and then we can decide who needs these more invasive procedures.
Yeah, we hope nobody needs any of them, but the reality is people are going to need them.
Yeah, and then importantly, what we do is prevention. So you want to start people on medicines early, and cardiologists are usually super aggressive with cholesterol. And of course, this being Heart Month, we have a lot of great ways to screen people. So of course, we always recommend
and the calcium screening test, right? Very important.
Yeah, I saw that yours was 0.
Yeah,
mine unfortunately not 0. My mother's father died at 39 or 40 from coronary disease.
Wow.
So I have a calcium score for 10 years, and I've been super aggressive with my cholesterol treatment. So I'm a huge proponent of calcium scores. So luckily, Baptist Health during the month of February for Heart Month does these calcium scores for $50. So you get a prescription from your primary care doctor or cardiologist. It's a great screening tool to see who's at long-term risk of coronary disease.
Wow. So it's good to know that your own cardiologist is taking care of his heart, right?
Absolutely.
That's good.
Yeah.
All right. So as we wrap up, any other toys that you brought for us? I call them toys. They're not really toys, but we're in the operating room, and when you're in a procedure room, these things that we work with, for us are toys, but they're there to help patients.
I brought this.
This looks dangerous.
This is a big spear, but this is a way. I was just wanted to show the size when you put in these TAVRs, when you put in these valves. It requires, these are much bigger catheters, much more complicated. So it requires a much bigger catheter than we use for the coronary. So, obviously more complications when you use bigger catheters. So definitely some more complications from that. But nonetheless, we've been doing this for quite some time, and the complications rate have gone lower and lower over the years. I also brought a couple of cool little gadgets to just show you how far our devices have come over the years. In the old days, people probably like Kath in the 80s, 90s remember that you used to put sandbags on the legs. People used to hold pressure for an hour. Now, of course, we're doing a lot of the procedures through radial, which is super easy. We have a little band to close that off. But now even we've become much better from the femoral approach, where we have a little device which closes off the artery right at the end of the procedure, so it makes it a very clean procedure. So right at the end of the catheterization, we'll slide a little guiding catheter in, and then put this little device in, or another device I brought, but this device has a little collagen plug with a foot plate that goes inside of the vessel. You pull this back, and then the collagen plug pushes right on top of the artery and closes it off immediately. And lower the risk of bleeding.
You don't have to hold pressure there for a long period of time.
No pressure, and people can get up over a shorter period of time. So it's
awesome.
It's really the procedure itself has come a huge way since I've been practicing. So it's been exciting.
So let's talk about the recovery. If you have a catheterization and you are seen in the office and you're scheduled for catheterization, you catheterize the patient, you put a stent. Patients are going home immediately afterwards?
With a diagnostic catheterization, definitely we send people home the same day, almost 100%.
Okay.
For angioplasty, we used to keep people for at least a day or two. Now there are some people, if you're higher risk, you're older, a lot of calcification, if it's a complicated procedure, we will keep you overnight. But there's many that we're sending home the same day.
Okay.
Getting this put in, we do the cath, do the stent right at the same time, send it home a couple hours later.
And
so
some of these more complex devices definitely have to stay a little longer, I would imagine.
Yeah, a TAVR for sure. You're in the hospital for a couple of days, not as long as open heart surgery, but definitely this is not a same day procedure.
And then what about the long-term recovery? Are they able to get back to exercise, get back to golf, tennis?
Yeah.
What is the progression like that?
From a coronary stent, it's really very brief. It's really just the puncture in the artery that's holding people back. Within a couple of days, if they have a 99% blockage that you've opened up, they feel better immediately, and they go out and their game probably improves relatively quickly. So really, they can go out, within a week or so and get back to their normal activities and enjoy life.
Yeah, this is something I learned very early on in medicine, is that really the only procedure or operation that you feel better after is really the coronary procedures and heart, because you feel better. Most of the time you have a procedure or a surgery on a patient, you feel kind of worse after the procedure because you're recovering, and the procedure itself doesn't really make you better immediately. But you alluded to that right now, that after a coronary, opening up of your coronary, or if you had a bad valve and I fixed your valve, you're going to feel immediately better afterwards. Is that the case?
Yeah, definitely. People, especially with the coronary disease, when you open a blockage and somebody having a heart attack, obviously they're coming in with severe chest pain, and immediately after the procedure, the chest pain is completely resolved, and they're incredibly thankful you stopped the heart attack. But even people that have a 90% blockage, you see in the office, that are having recurrent chest pain, they go home and that chest pain is frequently completely resolved.
Wow.
And
awesome.
So that's what we're aiming for.
So I want to say thank you personally, because obviously you've helped a lot of patients and obviously help in regard to preventing heart attacks and prevention, and obviously treating them. So thank you for doing that. And thank you for joining us today and educating and taking the time to bring some of these gadgets, devices, and some of these toys for our viewers to hear. And obviously, if you have a problem with your heart and you need a cardiologist, Dr. Dean Heller is here to help. And once again, here, Dr. Anthony Gonzalez with Miami Community Health. Taking care of your heart is very, very important. It's Heart Month. Get your calcium screening. See your cardiologist. Prevention is very, very important. Be healthy, be safe, and take care of yourself and your family. Have a great day.